Welcome to Cardiovascular Matters. Whether you are looking for answers for yourself or someone you love, we are here to give you the best information available. Each week, the founder of Cardiovascular Institute of the South, Dr. Craig Walker, and medical device sales veteran Terry Roberts discuss the causes, symptoms, treatment, and prevention of health-related issues stemming from cardiovascular disease. Now here's your hosts, Dr. Craig Walker and Terry Roberts.
Hello everyone, welcome back to Cardiovascular Matters. Today I'm here with Dr. Walker as always, but you might notice something a little different. Dr. Walker's wearing scrubs today, and we were getting ready for the podcast. I told him no need to change. He came right from his facility and into this studio, and one of the things we'd already planned on talking about, but it's just the timing is just incredible. We were going to talk about patients that have critical limb ischemia, and when is it too late to have an intervention? You know, a lot of patients will present, and they have this terrible issue going on in terms of pain and changes in their foot. And I'm going to let Dr. Walker talk about this, and just with all the experience that he's had, and I think we talked about this earlier. This was actually a situation my own grandmother was in at one time, and he was able to save her leg, and she lived with that leg and smoked like a chain smoker for about another 15, 20 years. But she lived a long life with her leg without losing it. So Dr. Walker, touch on that, because I know you see patients every day that have been told nothing can be done.
Yeah, that's really true. You know, we have an epidemic of amputation in our country and really, frankly, throughout the world. Amputations, for the most part, we think of the people who lose their legs in battle, but the vast majority of amputations aren't caused by battle. They're caused by blocked arteries to the leg. And those blocked arteries choke off blood supply and tissues start to die. So when tissues are in trouble in the legs, we call it critical limb ischemia. And recently that's been called chronic limb threatening ischemia, or CLTI. But what happens there? These are people who either have rest pain, where they have to keep their leg down for it not to hurt, so that gravity helps get a little bit blood to the legs, or they have ulcers on the legs that are not healing, ischemic ulcers, particularly on the distal part of the foot, or they have gangrene. And those three things make up what we call critical limb ischemia. And the majority of people with critical limb ischemia, if they don't do something to restore the blood flow, which is the cause of the problem, then they typically go on to lose that limb. The vast majority will go on to lose that limb. Now, a lot of people say, well, so you get your leg cut off, that sort of solves the problem, except it doesn't. Often these patients need many revisions of the amputation. The vast majority of patients now do not get fitted for a prosthesis where they walk again. And so even things as simple as turning over in bed at night become a very difficult chore. And almost a third of the people who have amputations are discharged to nursing homes, many of which never go on to be on their own again. So it's a real scourge. It costs the nation and the world a fortune. And when we can avoid amputation and restore blood flow, obviously it's a good thing. Now, in the past, really for limb salvage, the only option that was available was some form of bypass of a blocked vessel. And a bypass, typically a tube, starts from above where the blockages are, and then it is connected below where the blockages end, such that they're restoring flow. Well, the problem with that is it's a big surgery. Secondly, you've got to have a very talented surgeon to do it. Thirdly, you can't really easily repeat these procedures, and this is a progressive disease over the years. And then finally, many patients have blockages that go all the way down, and there's no getting around it, no going beyond it with a bypass graft. And so intervention has allowed many of these patients to be treated. And as you've seen in the past, I've done many thousands of these limb salvage interventions that really come to me from all over the world, from other continents as well. And so this morning, the reason I'm in scrubs, it was actually a day off that I was going to be working, but I had 2 patients that had called in, and they had true limb salvage problems, ischemic breakdown, tremendous pain in the legs. And so I went in to work on these patients. And all too often, the story is the same. Someone's told that, hey, we have no option except to amputate. Both of these were told that. But often that is the case. And I must say, amputation, in my opinion, sometimes is very, very necessary, especially if there's infection. But I think we overdo amputations in our country. I think that with appropriate training, we can avoid most amputations, not all. Sometimes if there's very active infection and things such as that, we can't heal those patients without an amputation. But in terms of restoring blood flow, in today's world, in the overwhelming majority of patients, we can restore blood flow. Now, both of the patients I worked on today had prior surgical bypasses. Those bypasses had occluded, and they had stayed open for many years, and there were certainly appropriate surgeries, done on these patients. But then when those closed, both were said, we need to amputate. Both of these patients were sent to me by other patients on whom I'd performed limb salvage interventions. Now, many say, well, that just doesn't last. And so that's one of the criticisms of that. Well, I can cite many patients who 20 years ago were told both legs needed to be amputated, who still have both legs. I can cite many examples where I've had to go back in as well, because certainly this disease is progressive, and sometimes you have to go back in to work. But several of those earlier cases that I've just mentioned were patients that we were one and done, and they stayed open. So it really depends upon the anatomy, what the vessels are like, how big the vessels are, how well the patients take care of themselves. Your grandmother, she had one of the problems that we face. She continued to smoke, which is certainly a big risk factor. But in today's world, that the first problem that we used to have in limb salvage is often people could not cross the blockages. Well, now with the tools that we have, and particularly if doctors spend the time learning how to use these tools to cross, it is indeed rare to not be able to cross the blockages. Okay, and so when I say cross the blockages, we cross the blockages with a wire or a tool such so that we can then deliver devices over that wire. That's how we're not just pushing these, we have to know where they're going. And so with appropriate training and time and experience, almost all blockages can be crossed. It's very rare that we can't cross a blockage. Then once we've crossed a blockage, we have to open the vessel, okay? And we have many tools to do that. We have atherectomy devices, which work by removing some of the blockage in its place. We have stents that allow us to overstretch the vessel and stop it from collapsing back again. We have tools that allow us, if there's clot or thrombus, to suck that thrombus out of the body. We have medicines that we can give to dissolve clot in certain cases. So we have a lot of tools that allow us to work here. And then some of these tools have been modified. For instance, we don't just have stents. Now we have stents that are medicated. We have stents that actually over time go away. They're bioabsorbable. The body absorbs them. We have many changes to many of the atherectomy tools to improve the likelihood of removing more material. And all of this has resulted in our ability to treat a lot of patients who historically just went straight from pain to amputation. Now, I think that's very important because there are very good articles showing early amputation is associated with far less life expectancy and a terrible quality of life. In fact, many amputees describe their quality of life as worse than most people who have lung cancer. Now, I'll say that again, because that's a very unhappy situation. These people are in chronic pain,
Right.
and often have, tremendous problems just going as far as to their bathroom or turning over in bed. Now, I've heard people trivialize the risk of amputation. In some of the best centers in the United States, not the average center, a below-the-knee amputation carries between a 5 and 8% 30-day mortality.
Oh, wow.
And above the knee, between 8 and 12%. That's within 30 days. But what's more frightening is that about half of those patients are dead within 2 years. And so it is not just about saving the limb, it's about saving the life.
Right.
And so the second component, first we must cross the blockage, then we must open it, then we must make sure it stays open. And staying open is dependent somewhat on what tools we've used to open. Do we use medicated stents? Do we use new biomimetic stents that will bend well in areas of the vessel that bend? Do we use atherectomy tools to remove what may have been some of the clot or other things? But it's also related to a whole host of medications that have improved. So we use antiplatelet agents, and everyone knows aspirin is one of those agents. It helps to stop clot in vessels, but we also have other antiplatelet agents. We have clopidogrel or Plavix, many people would know. We have prasugrel, which is known as Effient. And we have Brilinta, which are ticagrelor. All of these medicines make us less likely to form clots in these freshly treated vessels. In addition to that, there was a large trial done with the anticoagulant rivaroxaban, which many people know as Xarelto. And Xarelto, in a low-dose format, in 2.5 milligrams, taken twice a day, actually showed in the Voyager trial and in the Compass trial, they showed that we could improve outcomes in patients with peripheral artery blockages. So this is very important, Terry, and there's a continuum of peripheral artery blockages. We go all the way down to the person who has no symptoms at all. Then later on, we may have very mild symptoms, or a patient may start to note pain in the calves when they walk. And then ultimately, we can go on to the critical limb ischemia component. If we can get to these patients early and start them on preventive measures, lower their cholesterol, get them off of cigarettes, control their blood pressure, control the diabetes with new medicines that help to lessen the risk of going on to amputation. If we can do that, then that's a big deal. Plus, we have these new medicines which allow us to, after a procedure, have the patient be much less likely to clot off those areas. And I think these are godsends. And we've certainly learned that we can follow these patients more closely simply using ultrasound to make sure grafts are open and or that the vessels that we've worked on are open. And if these start to block, we can go in early before they become completely full of clot.
Right.
So you've seen some of these. What are your thoughts?
Well, I'm just curious about if you've got a patient, let's say, that comes in that's got critical limb ischemia, and they've got some changes going on, like in the foot that, I'm not going to say gangrene, but let's just say it's not looking healthy.
Right.
What medication would you follow that with? Obviously, you want to keep the vessel open so you can get a blood supply to that area, but is there anything additional you would do?
Sure. So, and it depends upon the stage of just how severely ill the patient is.
Right.
But standard medicines that we do to try to improve flow. So first we might check pressures in the feet and compare them to pressures in the arm. They should be the same.
Right.
If they're less, then we know we've got a blockage and we know we have to deal with that. So the first part of this treatment is to have someone on aspirin, and perhaps if they don't have bleeding risk, to add a drug, one of the other antiplatelet agents, the ones that I just mentioned. There's another agent that we often use early on in the disease process, and that medicine is called Pletal or cilostazol. Now, this medicine actually does improve the flow of blood in the leg when there are blocked arteries, and we're not 100% sure how it does that, but it does improve the flow of blood. And so we would start all of those. The other thing we would do if someone doesn't have wounds on the foot, would encourage them to start a walking program, because multiple studies have now shown that if we start an aggressive walking program, that patients start to develop their own natural bypass vessels better than others. So in the early stages, getting to this early is paramount, because often you can avoid any procedure at all. But once you get to a patient like the two patients I worked on today, where they have ischemic ulcers on the foot and the leg is hurting them at rest, at that point, I really think you're obligated to proceed with some method of restoring blood flow. If you're in a place where the expertise is purely surgical, there are typically surgical techniques that can help this. Or if you're in an area where there are people who are doing intervention, where they can, through needle sticks and sheaths, deliver therapy and restore blood flow, then that's good. And certainly the best of all worlds is if you have the opportunity to be exposed to both of those options, because both of those options are better than either one alone. So Terry, both of these patients that I worked on today, because today was going to be the day off, we're told their only option was an amputation. Both of these patients now have easily palpable pulses in the feet. Their pain is gone. And it's interesting because many of these patients, as soon as you're done, they want to hug you because their pain is gone. And of course, we're going to follow these, but these were usual, not an unusual outcome. I really do think somehow or another in the country, the advancement in the science of how to fix this has occurred faster than the education about what can be done. And because of that, I think many patients are taking a path towards amputation rather than a path towards limb salvage.
Right.
And hopefully we need to change that. Hopefully things like the podcast will help that.
Absolutely. And, if you're a patient out there, you have a family member that's having these challenges, again, it's very easy to get a hold of Dr. Walker's group. And like he is experienced in handling these critical limb ischemic patients as well as his partners in his group. But they can easily be reached at www.cardio.com. Reach out to them. Again, if you're looking for a second opinion or if you've got this situation, I can speak from my own personal experience. Years ago, my own grandmother was in a terrible situation and had bypass and was having the problems that we just described. And he was able to cross the blockage, open it up, and like I said, she lived for another 15 or so years and smoked like a chimney. But she kept her leg, and she was very, very happy. And I think everything should be done to avoid an amputation, because we talked about it earlier. There's certainly the impact on the patient, but there's also the impact on the family that has to care for that patient. So thanks again, Dr. Walker. I think this is a very important topic, and it's just so ironic that we're going to talk about it today, and you literally came from a case just like this an hour ago. I want to encourage everyone to like and follow us on the podcast, and it's easy to subscribe. It's free. Just on whatever device you're listening to, you can subscribe, and then you'll get notices when new podcasts drop. Thanks again, and Dr. Walker, thanks for all your expertise.
Thank you, Terry.
Thank you.
Thanks for listening, and please subscribe, like, and share this podcast with your friends and family. Join us next week for new topics and answers with Dr. Craig Walker and Terry Roberts on Cardiovascular Matters.